Good morning, everyone. Just wanted to let you know that we've just broken over 60 attendees right now. The conference will formally kick off at 8:15. I'd just like to make a couple of quick announcements. First of all, if Sophie Pumphrey would be willing to come join me on camera here, I just would like to just thank our team for really great support. So for those of you who were with us yesterday, you met or you saw that Pat White received our service award. And if you ask, who is Sophie Pumphrey? She is the Maryland Sleep Society's Pat White. So she has been our lead administrator. Sophie and I have been working together, and I will tell you, she is my right hand, my left hand, and probably 2/3 of my brain on an average day when we work together. I really want you to know that there are some really great people working behind the scenes to support the Maryland Sleep Society and to support making this conference the quality process and project that it is. Sophie has been really instrumental, and there are a couple of other people. Janine Feaster, who has been really a technical maven and a real asset to us to help us to make this work well, as well as Colleen George. And Clara Robinson from Log Me In has been working with us and has worked with Janine before. So I want to thank the fantastic team that we have that's made this conference work so smoothly. I really hope that you will have as wonderful an experience today as I felt we had yesterday. There's a couple of brief announcements I'd like to make. Sophie, is there anything you'd like to say? Sophie is from MedChi, and MedChi is the Maryland State Medical Society. So, Sophie,
I just want to say thank you for letting us manage your group. It's been a pleasure, and MedChi really appreciates the partnership that we have with you. So thank you all for being members of your society, and I've been really enjoying learning a lot about sleep during this conference. So thank you.
Back at you. And so I will say that please think about MedChi. We have a state medical society that supports so many subspecialty societies. So please, if you just Google them, take a look at their site. We're listed there as one of their member societies. Number two, please support our sponsors. We have 3 gift cards. I think it was for $100, $150, and $200. If you go into the chat room with the vendor and give them your name will be entered into a raffle. So for somebody here this weekend, they're going to be able to get a prize that's going to allow them to say, hey, I not only got 10 hours of CME, but I actually made a profit doing it. So please support our vendors. I want you to know that the cost of this conference is a bit more than what you actually paid, and this conference would not happen without our sponsor support. So please support our sponsors. And then the last comment I just want to make was that on CME, continuing education credits will be taken care of through the American Academy of Sleep Medicine. This has been a real asset. We've basically found the best way to get CME, which will be done through their website, and we will provide you with detailed instructions on what you need to do. We will be following up with a survey, so please understand at the end of the conference, when you were used to getting a piece of paper that you carried home that you put in your file so that you could wave that to anybody who needed to see it, we're going to take care of this electronically with you, but we are going to provide you detailed instructions on how to get that done. And the good news is that will be banked at the American Academy of Sleep Medicine so that when you need that at a future time, it will be there. One last comment, because I think I've got like about a minute left. A couple of our colleagues had shared their thoughts and concerns about a technical draft that has been written by AHRQ, which is the American Healthcare Research Quality Division of Health and Human Services. It's a technical draft on CPAP. It is not a final document. I have not yet seen this, but what I asked our producer to do for our meeting here was to just share that link. So you will see there's a URL that's been pasted into the chat box that will guide you to this technical draft. If you're looking for it yourself on Google, just if you type in AHRQ technical draft on CPAP, this document will show up. Please have a great conference. I think we have a really good group of folks speaking this morning. Have fun, and we look forward to seeing you in person soon. Thank you.
Good morning, everyone. I'm Grace Pien. I am a pulmonary and sleep physician at Johns Hopkins. I'm one of the Maryland Sleep Society board members, and I'm really pleased this morning to be moderating our our second literature review session of the conference. And we have three great presenters today. The first is Danielle Glick, who is a sleep fellow at the University of Maryland, and all of our presenters have chosen a couple of papers that were of interest to them, and hopefully to you, the audience as well. And I'm pleased to say that Danielle is also going to be coming on as faculty in just a few months at the University of Maryland in pulmonary critical care and sleep. So Danielle, take it away.
Thank you so much, Dr. Pien, and good morning. I am going to be going through two articles with you this morning. Let's see if I can get this to work. Yes, all right. I have no conflicts of interest to disclose, and also the accreditation statement is here as well. So the first article that I wanted to discuss this morning is the natural history of sleep-disordered breathing during rapid eye movement sleep and its relevance for incident cardiovascular disease. This was a study done by Aurora and colleagues and published in the Annals of ATS last May. As background, we know that sleep-disordered breathing occurring only during REM sleep is common, and we know that that happens for a number of physiological reasons. Despite the increased hypoxemic burden, and the outcomes related to these events are less well understood. So there's mixed data on daytime sleepiness and other functional outcomes. There's the thought that PAP therapy may be useful, but that remains a little unclear. And we do know that it is independently associated with adverse cardiovascular outcomes. The role of treatment, however, for sleep-disordered breathing that's isolated to REM sleep is undefined. So the objectives and hypotheses for this particular article were to first characterize the natural history of REM-related sleep-disordered breathing, determine the effect of demographic and anthropometric factors on disease progression, and finally to assess whether progression from REM-related sleep-disordered breathing into NREM sleep was associated with incident cardiovascular disease. Methods for this study: this was a prospective cohort study. They utilized data from the Sleep Heart Health Study. All participants were over the age of 40, and they were not currently receiving treatment for sleep-disordered breathing. Inclusion in the study required the performance of two polysomnographies, one at baseline and one at follow-up. And the inclusion criteria based on those two studies were that the NREM AHI was less than 5 per hour at baseline, so no sleep-disordered breathing in NREM. And then the follow-up PSG had to be done about 5 years post-baseline, and both studies had to have greater than 15 minutes of REM sleep during the studies to be included. The PSGs were actually done unattended at home, and so as you can see, I've included the picture here of what the device was that they used. It was the Compumedix P series, and as you can see, it's a pretty extensive device. This is actually a full unattended PSG, and I emphasize that to just state that we're very certain that REM was captured during the unattended PSG at home, because that is obviously important when you're asking the question about sleep disorder breathing during a particular stage of sleep. So, and then finally, they assessed cardiovascular disease as assessed by occurrence of cardiovascular events, and that was captured via surveys that they did at the various follow-up times. So for results, so just to discuss the baseline characteristics of this group, there were roughly 1,900 participants, of which about 2/3 were women and a third of them were men. They had a mean baseline age of about 60. Mean baseline BMI was actually on the relatively low side at around 28 for both groups. The majority were white. There were very few that were of minority descent, and a large portion actually of Native Americans. And then the overall baseline AHI was 2.7 or 3.0 in women and men respectively. And this is important just to point out that these were people who did not have NREM-related sleep-disordered breathing. So they would not have met characterization for OSA. The baseline REM events in general were normal, so over half of participants in both had REM AHI less than 5, and about 6% had severe REM-related sleep-disordered breathing at baseline. So the first thing assessed was whether or not progression into NREM sleep was related to baseline REM AHI. So what did the baseline REM sleep disordered breathing tell us about progression over time? And the good news here is that especially in women, over time, the REM-related sleep disordered breathing actually was progression to stability. So in general, you can see here the baseline REM AHI is listed, so 5, so normal, mild, and then moderate to severe. And then over time at follow-up, you've got NREM and REM AHI, and what this is basically showing you here in these red boxes is the NREM AHI less than 5, that's normal. And the majority of women, at least, did not progress over those 5 years into having sleep-disordered breathing during NREM sleep. This was somewhat less true for men. You can see there's a greater proportion that did have some development of NREM sleep-disordered breathing. But in general, we can safely say that REM sleep-disordered breathing generally doesn't progress. So what happens when it does, and what might predict that? So what they wanted to look at was, of course, risk factors that we know affect sleep-disordered breathing. So BMI. So in men specifically, a higher BMI or a change in BMI of greater than 1 kilogram per meter squared was associated with a more likely progression from REM-related sleep-disordered breathing into NREM sleep. This was not true of women, but significantly true in men. And then when looking at age, in women specifically, it did increase the odds of progression from REM-related sleep-disordered breathing into NREM. Also, the higher the baseline REM AHI was, the more likely they were to progress into NREM sleep. And if one was present, it was more likely that the other, if one progressed, it was more likely that the other would also progress. And then finally, their last question was, what was the association with cardiovascular disease? And what they found was that in women who had baseline REM-related sleep-disordered breathing, so essentially a REM AHI greater than 5, that progression into NREM sleep of sleep-disordered breathing was independently associated with incident cardiovascular disease. This was not true for men. So what are the implications of this study? This was a large study, a large cohort that was followed over a relatively short period of time. There was a range of severity present, so that gives us some good generalizability there, but the baseline severe REM AHI was relatively rare. Also, they used a strict scoring criteria where they looked at hypopneas being defined as a greater than 4% DSAT. This does fill an important knowledge gap in that it suggests that the natural history of REM-related sleep-disordered breathing is stability rather than progression into sleep-disordered breathing at all stages. BMI and especially an increase in BMI predicts progression, especially in men. And there is a strong interdependence of REM sleep-disordered breathing and NREM sleep-disordered breathing. So progression during one was related to progression during the other. And then with respect to cardiovascular disease, development of NREM-related sleep-disordered breathing was predictive of cardiovascular disease, but only in women. So the question that I always ask myself when I read the literature is, would this change my practice? And the answer that I came up with for this particular study was maybe. So if I see REM-related sleep-disordered breathing in isolation and it's a woman, I might consider treatment for her earlier. If it's a man, I might just be more aggressive with my counseling on modifiable risk factors, especially weight, but I might not be so quick to consider treating them. And that is all I have for that study. If there are any questions or discussion points, I'm happy to field those before moving on.
Hi, Danielle. One question that I had actually was, I noticed that for women, there was not the same effect of body mass index that there was for men. And I just was wondering whether there was any ability in the study to look at whether menopausal status actually contributed to the progression to sleep apnea? Or
That
high
is a
rate
really
high?
interesting question. I mean, certainly the age demographic would suggest that perhaps there was, although at baseline they were 60, so perhaps they were already postmenopausal. They didn't discuss that, but that's an interesting consideration.
I don't see any other questions, so go on to the next, please. Thanks.
Okay, sure. So the next study that I wanted to discuss was the SAMS randomized clinical trial. This was the effect of multi-level upper airway surgery versus medical management on the apnea-hypopnea index and patient-reported daytime sleepiness among patients with moderate or severe obstructive sleep apnea. This was done by McKay and colleagues in Australia and published in JAMA in September of 2020. So background for this one is that we know, of course, again, that adult OSA is a common disorder with significant associated morbidity and mortality, including increased daytime sleepiness and motor vehicle accidents, reduced quality of life, and increased cardiovascular risk. Treatment with CPAP or a mandibular advancement device is standard. However, half of patients may be undertreated due to lack of tolerance or treatment refusal. And then there are surgical alternatives that exist, but they have not been rigorously studied. So one of the surgical procedures that is most common for the treatment of OSA, or at least used to be more common, is the uvulopalatal pharyngoplasty, or the UPPP. And this was the predominant surgery performed prior to the advent of CPAP devices in the 1990s. And this graphic here basically just demonstrates to you the all of the things that happen during the procedure. So without getting into it too much, essentially you're having reduction of the soft tissue in the posterior pharynx, and you're removing the uvula as well as the tonsils and adenoids, and essentially just creating more air space to prevent upper airways resistance and resistance to flow of air, especially overnight. The problem with this procedure and with many surgical procedures is that there is a lack of randomized trials to support its efficacy. So this actually fell relatively, not out of favor, but as we heard yesterday during the discussion of the hypoglossal nerve stimulator, it's generally not performed. It's a very large surgery and can have a really significant recovery time. And the question is whether or not there's actual benefit from it and how much that does benefit patients. Another procedure is radiofrequency tissue ablation. And so the way that this works, it's kind of cool, I think. So radiofrequency reduction of the base of the tongue. Essentially, you're using an electrode here to insert some saline, and then that gets heated. And with radiofrequency, the saline ions become heated and cause local tissue destruction. And then you do that in a number of different locations. So each one of these little ovals would be, across the base of the tongue here. And then over time, those lesions get resorbed, and that results in reduction in tissue volume over time. So in the trial at hand, they did about 7 to 9 lesions. I think in the literature, it's reported somewhere between 3 and 8. So what was their hypothesis overall? Generally, they said that they were looking to explore whether multi-level surgery would be more effective than ongoing medical management in the improvement of OSA, and their outcomes would be to measure a decrease in the frequency of sleep apneas and hypopneas, as well as a reduction in daytime sleepiness. The population here, this was a multi-center parallel group open label randomized clinical trial. This was performed at 6 academic institutions in Australia. And the patients that were randomized to the surgical arm underwent multi-level surgery, including both the UPPP and radiofrequency tissue ablation. So they were randomized either to surgery or 6 months of intensive medical management. Inclusion criteria, these were adults aged 18 to 70. They had moderate to severe OSA. Their BMI was less than 38. Initially, they actually set that cutoff at 35, but because of slow enrollment, increased that up to 38. They had to have had an Epworth Sleepiness Scale of over 8, and also had to have either failed or refused CPAP and, if appropriate, a mandibular advancement device. Exclusion criteria included significant medical or psychiatric comorbidities, high anesthesia risk, pregnancy, specific anatomical contraindications to surgery, and a Friedman stage 4. So methods each of the patients that were included in the study had either 6 months they were followed for 6 months either after the surgery or initiation of medical management. Each individual was assessed by a sleep physician at 1, 3, and 6 months. At that time, they basically had demographics, medical information, obstructive sleep apnea treatment, and BMI assessed. And also at baseline and then at follow-up 6 months, they underwent PSG, MSLT, and blood pressure measurement. The scoring for the PSGs was done according to the AASM 2007 manual, and a hypopnea of note was defined as a 50% reduction. In the surgery group, of course, they did report all serious adverse events. So what did they find? They screened 612 patients, wound up with 102 that met their inclusion criteria, randomized 51 in each arm, and wound up with 50 undergoing surgery and followed up, and 49 in medical management. In general, the mean age was in the early to mid-40s. The majority of participants were men, about 80% in both groups, and the majority of them were white. The mean baseline AHI in both groups was similar at around 47, and the Epworth Sleepiness Scale was also similar, with the surgery group being slightly higher at 12.4 compared to the medical management at 11.1. Their anatomy was relatively similar, and their BMI was also somewhat similar, although in women it was higher in the surgery group than in the medical management group. And what did they find? So they found a statistically significant greater improvement from baseline to 6 months in the surgery group in both of their primary outcomes of AHI and Epworth Sleepiness Scale. So what they found here was, as you're looking at the baseline and then again at 6 months, in the surgery group, the AHI was reduced from 47.9 to 20.8, whereas in the medical management group, the reduction was much less, from 45.3 to 34.6, and this was statistically significant. Similarly, the reduction in Epworth Sleepiness Score from baseline to 6 months in the surgery group was 12.4 to 5.3, whereas in the medical management group, it was 11.1 to 10.5, and again, that reached statistical significance. So what they showed essentially was that surgery resulted in significant reductions in sleep apneas and hypopneas, as well as improvement in daytime sleepiness in moderate to severe OSA failing traditional management. What I did not show was the secondary outcomes, but they did show improvements in other PSG measures, such as arterial oxygen saturation measures, cortical arousal frequency, in addition to partner-related or reported snoring, patient-reported sleep-specific quality of life, and overall general health status. MSLT and blood pressure values did remain unchanged. So strengths and weaknesses of the study. So the strength was that this was a multi-level surgery, so it wasn't just the 2 procedures done at the same time, and these are relatively standard techniques. And this was a randomized trial, and I really highlight that because obviously that's our gold standard for anything, but specifically in surgery, that's relatively rare and sometimes difficult to do. So really, this was very robust for this particular investigation. And it was a decently large sample size for a surgical trial. And the follow-up time of 6 months, I think you could look at that as both a strength and a weakness. So in the strength column is the fact that previous trials evaluating the UPPP especially, the follow-up time was only about 3 months. So this was a little bit more robust from that sense. However, of course, 6 months, especially for a large surgical procedure that long-term could have outcomes like stenosis or, poor healing or other complications, would not be considered a long period of time. Weaknesses, in addition to the follow-up time, would be blinding was not possible. Obviously, they didn't have these patients undergo a sham surgery. Generalizability is severely limited by the relatively homogeneous population. I think that's just a part and parcel of where the study was performed. And then the benefit in severe obesity, elderly women, anatomical limitations, and then women as well, was also limited, again, by this homogeneous population. So maybe this is good in younger white men, but we're really not sure what to make of it in the rest of the population at large. So would this one change my practice? I think I might be slightly more inclined to refer patients for surgery, as there does seem to be some benefit, but it's not curative. So remember that even though there was a significant reduction in AHI, there was still a significant amount of residual apneas and hypopneas that wouldn't preclude the need for treatment. So I would want to see longer-term outcomes before being more aggressive about considering this therapy. And that is all I have.
I'm just looking in our question box. There is a question about, I think, your first paper actually, which is REM-dependent sleep apnea diagnosis. Does the diagnosis of REM-dependent sleep apnea meet insurance requirements for reimbursement for patients to be treated?
So I'm pretty sure the answer to that is no, and so that is certainly a complication. I think if you have a patient who maybe has mild sleep apnea, but then the REM component of that is, moderate to severe, and you have other comorbid conditions, you might be able to make the argument for that. But in a lot of these patients that they included in the study where they had baseline NREM AHIs of less than 5, you might be a little hard pressed to get that covered.
Okay, and then there's a second question about whether in the second paper you presented, whether there's any plan to continue to follow up those patients for longer. And then we're going to move on. Yeah,
I'm not actually sure whether there's going to be a follow-up on that or not. I hope so. I think that would be really interesting. I think it was important for them, obviously, to get the results out because it was a pretty important study, but I would hope that they would be able to follow those patients over time.
Okay, great. Thank you so much, Danielle.
Thank you.
So I'm going to introduce our second speaker, who is Dr. Umer Shoukat. And Dr. Shoukat is a sleep fellow at the University of Maryland. He came to Maryland from Abington, I believe, and actually is headed back there after fellowship in just a few months. And so, Dr. Shoukat, go ahead. You have the floor. Thank you.
Thank you so much, Dr. Pian.
And can we get Dr. Shoukat's slides up, please?
Thank you. Good morning, everyone. I have no conflicts of interest to disclose. So the first paper for today, it was published in May last year in JAMA Otolaryngology, head and neck surgery. The authors are from Emory University. And it's about evaluation of therapeutic positive airway pressure as a hypoglossal nerve stimulation predictor in patients with obstructive sleep apnea. So as a background, there has been a growing interest to determine factors that predict the outcomes of patients with hypoglossal nerve stimulation. And recently, the retrospective data from the patients having these procedures has shown that low therapeutic positive airway pressure had a positive outcome, and they achieved greater success with the procedure. So I know the topic was covered in detail by Dr. Egan yesterday, but just to summarize, basically the hypoglossal nerve stimulation is a procedure that is primarily for patients who have troubles with PAP adherence, and the inclusion criteria are they should have AHI anywhere between 15 to 65, BMI less than 32. The component of central or mixed apneas should be less than 25%, and on the DICE examination, the absence of concentric collapse. And this consists of 3 components. There's a sensory lead that basically senses the inspiration and changes in the intrathoracic pressure. There's a pulse generator, and then there's a stimulation lead that basically stimulating components of the hypoglossal nerve, and then protrusion of the genioglossus muscle, basically increasing the space in the hypopharynx, and that's how eliminating the obstructive events. So the hypothesis for this paper was that the therapeutic nasal positive airway pressure at the level of soft palate during the drug-induced sleep endoscopy can predict response to hypoglossal nerve stimulation in patients with obstructive sleep apnea, and that the mean palatal opening pressure as measured by the nasal positive airway pressure during the DICE exam will be lower in responders compared to non-responders. And for the purpose of the study, the responders would be all the candidates who showed greater than 50% reduction in the AHI post-procedure. So the sample size was 27 patients. All these patients are enrolled from a single surgery clinic. Basically, the inclusion criteria are pretty similar to hypoglossal nerve stimulation in general. All patients were older than 22, had a baseline AHI of 15 to 65, absent of concentric collapse, and less than 25% central or mixed apneas. And then nasal positive airway pressure was applied during the drug-induced sleep endoscopy. And that's how they evaluated the palatal opening pressure in the real time. All these patients, they had an in-lab sleep study for titration purposes after the implant. And all these patients also underwent a home efficacy study at the interval of 3 months post-activation. Another thing that they did in the study was to provide a positional parity between the sleep study findings and the DICE examination. They also separately evaluated patients who had residual supine AHI of the titration study. And 9 patients were included from the secondary analysis because they did not sleep in the supine position. So comparing the results for sleep study data and the DICE examination for our overall efficacy group, including all the patients, even in the patients who slept in the supine position as well. The mean age was 62, BMI was 28, baseline AHI on the diagnostic study was 37.4. And for this study, they specifically focused on the pressure requirements at the level of velum. They did not separately focus on all the other anatomic sites, and at the pharyngeal level. And what it shows is that the responders had lower requirements of nasal positive airway pressure compared to the non-responders, requiring 5 centimeters comparing to 9.2 centimeters of water pressure. And the results were very comparable when they separately analyzed the supine responders and non-responders. And also at that level, the requirement of the pressure was 4.7 centimeters of water compared to 9.1 centimeters of water for non-responders. And in both of these groups, we also noticed that the baseline AHI was worse in responders compared to non-responders as well. This slide goes over some predictive characteristics. So on the left-hand side, we have this receiver operating curve and area under the curve. So just taking into account the age, sex, and BMI, the area under the curve for predictive ability for the responders was only 0.79, and we see that when we add nasal PAP into the mix, the predictive ability and area under the curve has improved, and it increases to 0.89. And they also focus on this nasal PAP pressure during the DICE exam of 8 centimeters. because it provides a well balance between all the measures of sensitivity, specificity, negative and positive predictive value. And if we increase the pressure, the sensitivity increases, but the specificity decreases, and that's the same for decreasing the pressure as well. So just to summarize, their primary outcome was to see if the responders would show lower mean palatal opening pressure than the non-responders. And it does show that they're requiring lower pressures. And the similar results for secondary outcome of the patients in supine AHI group as well. Both these groups had lower requirements of nasal positive airway pressure. Limitations of the study is that the sample size were very small. They were not able to have a baseline supine data for the people in the study. Also, all the pressure measurements are in supine position, and there's a lack of objective measures of mass leakage, and they were not able to measure flow as well because the pressure ramped up too quickly for the flow measurements. And also because there was an inability to introduce REM sleep because drug-induced sleep endoscopy basically mimics more so non-REM sleep than the REM sleep. But the strength of the study was that they were able to have a full night of efficacy home sleep study rather than taking data from the titration study. And they also separately analyzed the residual supine AHI. So the implications of the study are that the nasal therapeutic positive airway pressure can represent a very low risk and cost-effective tool because all the patients undergoing evaluation for hypoglossal nerve stimulation do require this procedure. And the further studies can be aimed at maybe different anatomical sites, and we can do some more endotyping and selection of patients who would respond favorably to the procedure. The concerns will be that how to standardize the reporting, and also how feasible or how logistically it will be possible to implement this like a strategy of implementing PAP in the ENT office setting. Do all these patients will have to come into the lab for these procedures, or is there a subset of ENT physicians who maybe perform these procedures in their office settings and may not have access to like sleep techs or some other things that they would be needing to make that happen in their office setting. So that is all I have. I can take any questions.
So Umer, I just have to say I was impressed in their data just by the fact that the responders actually did have more severe sleep apnea, but they had the finding of the lower pressure, and it does seem that this would be a really interesting thing to look at prospectively in a larger number of individuals at multiple centers to see whether it bears out, since it seems like it could really, help clinicians, help the ENTs figure out who is going to be a responder.
That's actually one of the points that they make in the conclusion, that they would like that to be broadly implemented as possible across multiple centers to see if the results are generalizable.
Yeah, and I see a comment, often we see that people habitually avoid sleeping supine when they sense being unable to breathe. If they eliminated 9 patients because they didn't sleep supine, what does this mean for results? And so I, agree that that may be something that is telling us something about the subject population as well. But I am going to ask you to move on since we're getting a little bit behind time, and to just go on to your second paper.
So my second paper is about transvenous phrenic nerve stimulation to treat idiopathic central sleep apnea. It's by Dr. Javahari, and it was published in Journal of Clinical Sleep Medicine. So just a background about idiopathic central sleep apnea. It's basically a diagnosis of exclusion, and when all the other known causes of central sleep apnea have been excluded, this is a consideration. And the pathophysiology is understood to be related to increased controller gain and chemosensitivity to carbon dioxide. It generally affects middle-aged and elderly men more than women, and up to this date, there have been no prospective long-term study on the treatment and management of idiopathic central sleep apnea. The hypothesis by the authors for this study was that transvenous phrenic nerve stimulation is a long-term, safe, and effective treatment for idiopathic central sleep apnea. A brief overview of phrenic nerve stimulation by Remedy device that they use for this study and this trial. So basically, it's composed of three components. It has an optional sensing lead that is placed in the diaphragm. They have a pulse generator and a stimulation lead that is either placed in pericardiophonic vein or brachiocephalic vein. And what happens is that for the amount of the time that the device is titrated for overnight, it continuously stimulates the unilateral phrenic nerve and causing the diaphragm to contract and creating negative intrathoracic pressure throughout the time that it's being active for. The study population for this paper is actually part of the original Remedy System pivotal trial that included all the moderate to severe central sleep apnea from any reason. So for this paper, they only taking the subset of 14 patients that did not have any known other cause of central sleep apnea. The inclusion criteria was total AHI of greater than 20 and central apnea index of 50% or more, obstructive apnea index of less than 20%. They should not have had any cardiovascular known disease. They should not be on opiates and absence of Cheyne-Stokes breathing. All these patients had transvenous phrenic nerve stimulation device implanted, and following these patients, they were assessed for quality of life by multiple metrics, including Epworth Sleepiness Score, Fatigue Severity Score, as well as Patient Global Assessment at the level of 6, 12, and 18 months. So going through the results of these studies, the remarkable thing about that is that central apnea index showed a significant improvement at the 6 months interval from 25 to 3, and then the effect was sustained at 12 and 18 months. And there has been improvement in the arousal index as well from 32 to 16 at 6 months, and it was maintained at 18 months as well. This is a graphical representation of the results that we just talked about. As we can see that all the metrics, including central apnea index, overall AHI, arousal index, they showed improvement. Remarkably more so in the first 6 months, and the effect kind of sustained through the 12 and 18 months period. And then they also measured some quality of life metrics. So the baseline Epworth Sleepiness Score for this patient population was 14, and that improved to 7 at 6 months and sustained at 12 months. Fatigue Severity Score of 4 or above represents fatigue, and this patient population had a baseline of 4 that improved to 3.1 at 6 and 12 months. And then EQ-5D index basically is just an analog scale of overall health. It's the perception of patients about their own health. And it's graded from 0 to 100, considering the worst health state and the best health state. And there has been improvement in that scale as well, going from maybe around 80, 85 to close to 100. And that's a subjective score. They also asked people at the follow-up visits about generally how they felt about the procedure, if they would like to have that procedure again. And at follow-up visits at 6 months, 46% of the patients, and at 12 months, 71% of the patients said yes, that they would like to have that procedure again, considering how they felt about that. The limitations of the study was that it was a very small sample size and it's an observational study and subject to bias. But the issue with the sample size with this cohort is that it's a relatively rare disorder, and to have a very large sample size with this etiology, it's not very possible, and all the studies have been up to this date on this etiology have been very small patient populations, usually like around 4, 5, 6 patients. The strength of the study, however, is that it was a relatively long-term follow-up, and they're going to continue to follow these patients in the future as well. And they also were able to collect a variety of quality of life metrics as well. So phrenic nerve stimulation can be considered as a potential long-term treatment option for idiopathic central sleep apnea, with the future randomized controlled trials with relatively larger sample size if possible are needed. Also considering the efficacy or safety of this treatment, there was not any reported serious adverse effect to the patients who had these procedure done, and they did have to exclude 2 people from the study because one had a lead failure and one had some other cause-related death from myelodysplastic syndrome. So original cohort was of 16 patients, but the procedure-related safety was well documented. So that's all I have for the slides, and I can take any questions.
Hi, we do have one question, which is, and I think you actually answered this just because I don't believe you had any conflicts of interest. Were you in contact at all with the sponsor in the remedy study?
No, sorry, I should have disclosed that. No, I had no conflicts of interest.
Okay. Okay, I think that's all we have. So in the interest of keeping on time, I'm just going to move on to our third presenter. Thank you very much, Umer.
Thank you.
So our third presenter this morning is Dr. Jennifer So. Dr. So was kind enough to step in when we needed a sixth presenter for the literature review. Dr. So is actually an assistant professor of medicine at the University of Maryland. She did her pulmonary fellowship at Temple, her sleep fellowship at the University of Pennsylvania, where I also trained, so that's a little close to my heart. And so she came to Maryland in 2019, and in addition to her sleep medicine capability, she's also the director of the MICU, I believe, at the Baltimore VA. So take it away, Jennifer.
Okay, good morning, and thank you for the kind introduction and for having me here. So today I will be presenting 2 papers. First of all, I do not have any conflict of interest to disclose, and here's the ACCME disclosure. So the first study I'm going to present today is a study that was published by Masa, and I believe Dr. Mokwisi had also spoken about this Glick clinical trial yesterday. So this study is a secondary analysis looking at the echocardiographic changes with positive airway pressure therapy in obesity hypoventilation syndrome. This was published in the Blue Journal last year in March 2020. So quickly going over the obesity hypoventilation syndrome, which is very prevalent and it has been getting more interest recently. And this is the diagnosis of OHS is defined by presence of obesity, often defined as BMI greater than 30, which often is associated or is linked to decreased respiratory drive in patients. It is also associated with sleep disorder breathing, which in combination often can lead to daytime hypercapnia as well as nocturnal hypoxia. And what's interesting about obesity hypoventilation syndrome is that about 90% of these patients have concomitant obstructive sleep apnea, and about 70% of these patients actually have severe sleep apnea. And one of the reasons why OHS is so interesting is that it has pretty significant cardiovascular implications. Patients with OHS often can have pulmonary hypertension, significant RV dysfunction, as well as systemic hypertension. And with all these, they are at a significantly increased risk for cardiovascular mortality as well as morbidity. The treatment of OHS has been of great interest, and many studies have been performed. First and foremost, the treatment with TAP therapy has been known to significantly improve the overall morbidity and mortality. And in fact, there have been many studies that have looked at the effectiveness of OSH treatment with CPAP versus non-invasive ventilation, such as BiPAP or AVAP. And what they have shown so far is that PAP therapy in and of itself do have significant improvements in the overall outcome, as well as quality of life, CO2 levels, and overall shortness of breath and awake respiratory function. However, there is significant lack of data looking at the effectiveness of non-invasive ventilation versus CPAP on treatment CPAP on cardiac structure and function, and specifically looking at the cardiovascular morbidity and mortality in these patients. So what this particular study looked at was it wanted to compare the effectiveness of non-invasive ventilation as well as CPAP in treating OHS, specifically looking at the structural and functional echocardiographic changes. And the hypothesis that this study proposed was that the long-term treatment of obstructive obesity hypoventilation syndrome with non-invasive ventilation will lead to greater improvements in pulmonary hypertension and left ventricular function compared to CPAP treatment alone. So the methods of the study, so this again was a secondary analysis of the PICWIC project, which was a randomized controlled trial that was designed to determine the comparative medium and long-term effectiveness of non-invasive ventilation and CPAP, as well as lifestyle modification. And this study had a pretty long follow-up and a very big number of patient participants, and they followed the patients for about 3 years. And this was a multi-center, open-label, randomized controlled trial that involved 2 parallel groups and 16 sites, all in Spain. And again, the main effects that the study looked at was the effectiveness of NIV versus CPAP. And this particular study actually collected a lot of different variables, including echocardiographic measures, arterial blood gas, blood pressure, spirometry measures, which include FEV1s, FEV3, 6-minute walk test, as well as dyspnea score, which include MMRC, mostly used for this analysis. And it was an intention to treat analysis. The inclusion criteria for this study, the patients first and foremost had to meet the criteria for OHS, and their BMI criteria was greater than 30. They had to have stable hypercapnic respiratory failure, as well as absence of any chronic obstructive pulmonary disease. And of course, as for diagnosis, they had to not have any other potential causes that would explain hypercapnia, such as severe COPD or a neuromuscular disease or overall hypoventilation from alternative causes. This particular study actually also included patients with severe sleep apnea only, so AHI had to be greater than 30, and they had to have also absence of any other sleep disorder such as narcolepsy, RLS, and have to be able to tolerate PAP treatment for at least 30 minutes. And these are some of the exclusion criteria, so such as chronic debilitating illness, chronic nasal obstruction and the inability to participate in questionnaires, and of course, lack of informed consent. So I know this is a busy study, but I just want to put this up for people to get a basic sense of the patients that were included in the study. So overall, the CPAP and NIV groups are relatively evenly split. The BMI of these patients are pretty high, the average BMI of around 42 to 43. Another notable finding here is the baseline CO2 was around 49 to 50, which is elevated, but not severely elevated, but can be often in the range of those with OHS. And the overall AHI, as I mentioned, was quite severe, around high 60s to 70s. In total, there were 196 patients, and there were about 3-year median follow-up time and about 6-hour median adherence in both groups, which is pretty impressive. So this study was very comprehensive. They have looked at a lot of different variables, a lot of different measurements from echocardiographic data as well as from the surveys and the testing that they did. I have included a few results here. So this was one of the primary outcomes of this study, which was looking at the effectiveness or the pressures in the pulmonary artery as well as the right ventricles as a surrogate marker for pulmonary hypertension through the echocardiographic measurement. And as you can see here, for both the NIV and PAP group, there were some notable improvements in the use of both NIV and CPAP over a 3-year period in those with OHS. However, there were no significant differences between the two groups, but definite improvements in terms of measures of pulmonary hypertension in groups who were treated with a PAP therapy. Another outcome this paper wanted to assess was the diastolic dysfunction. So these are the various echocardiographic measures of diastolic dysfunction. And what is notable from this study is that patients who were treated with both NIV and CPAP had notable improvements in various measures of diastolic dysfunction. However, again, statistically, there were no significant differences in terms of between the two groups, especially when they were adjusted and for the longitudinal 3-year period. They also looked at the changes in left ventricular systolic function by using these two parameters, the left ventricular ejection fraction as well as the telesystolic diameter. Here, there were no significant changes over time as well as no significant differences between the two groups. So overall, the echocardiographic measures of PAP therapy in OHS show that there is an improvement in the LV hypertrophy as well, or the diastolic dysfunction, as well as overall LV and pulmonary hypertension pressures. However, there were no significant differences between the CPAP group versus the non-invasive ventilation group. They also, however, noted that those people who were treated with PAP therapy had significant improvements in overall systolic blood pressure, the carbon dioxide, as well as oxygen levels in the arteries, as well as the pH, the bicarbonate levels, and overall spirometric measures with FEV1 and FVC improvements. But again, there were no differences in between those two groups. They did not see any significant improvements in 6-minute walk distance, and the dyspnea also tends to increase in both the PAP groups as well as the rate reduction. And there was also significant reduction in the requirement for daytime supplemental oxygen in both groups. So this study was a very good study. So first of all, one of the strengths of this study was that it was one of the largest randomized controlled trials comparing the long-term effects of NIV versus CPAP in patients with OHS. And what they were able to do was also compare kind of the differences between the immediate, more the short and medium-term effects of PAP therapy compared to the long-term effects, which there were some changes. It seemed that the patients shorter term tend to benefit more from NIV, but over longer term periods that there is no significant difference between the NIV versus CPAP. There were some limitations to this study. So first of all, the sample size calculation was not performed, a priority for the secondary outcome. There were no control group for longitudinal data analysis, for example, having a control group where they had more of a lifestyle change rather than a PAP therapy. Patients and investigators were not blinded, although the people who were reading the echocardiographic measures were blinded. And again, as with all studies that involve some sort of technical measurements, there can be some potential variability with the equipment and technician skills, as well as less accurate, and the echocardiographic measures being less accurate than the more invasive right heart catheterization results. And again, the study was performed in Spain only, and they only included patients with severe sleep apnea. So the implications of this study is that, or the findings, is that patients with obesity, hypoventilation syndrome, and severe OSA, long-term PAP therapy improves systolic pulmonary arterial pressure as well as the left ventricular diastolic dysfunction, which can be measured by echocardiogram. There were no differences between the non-invasive ventilation group as well as CPAP group. And so this study encourages treatment of sleep apnea and OHS and utilization of echocardiographic measures in patients with obstructive sleep apnea, obesity, hypoventilation syndrome, and obstructive sleep apnea. Okay, and yeah.
Actually, you can just go on to your second paper. We're running a little bit behind. Okay.
Yeah. So I'll go through this very quickly. So this is the second paper that I will be presenting. This is a study by Octavian and colleagues published in Journal of Clinical Sleep Medicine just last year, February 2020. And the study looks at what this study looked at was obstructive lung disease and obstructive sleep apnea, or the combination of both, which they called as old OSA cohort, and the overall outcomes in these groups. And this was a 10-year long-term study. So overall, the background of COPD, asthma, and OSA are one of the most common kind of disorders that we see in pulmonary clinics as well as in sleep clinics. Often patients can have combined diseases of COPD and OSA as well as asthma. And studies have been shown previously that the overlap syndrome between COPD and OSA have significantly worse outcomes, both in mortality and morbidity, compared to the COPD or OSA disease on their own. Asthma and OSA overlap syndromes have been described, however, they have not been very well studied, as well as the triple therapy of patients who have both ACOS, which is COPD and asthma combined, as well as OSA, have not been well studied at all. There is a significant lack of data on prevalence as well as outcome implications of the various overlap syndromes between the obstructive lung disease as well as sleep apnea. So the hypothesis of the study was that the coexistence of at least two of the disorders that I had just mentioned adversely and independently affects the long-term survival of these patients. And a secondary hypothesis that this study had was that the PAP therapy, both including non-invasive ventilation and CPAP in those with OSA, as well as any of these overlap syndromes, will lower mortality. This was a large longitudinal observational study, also known as the obstructive lung disease and OSA, old OSA cohort. And this enrolled patients from Atlanta VA starting year 2008 and followed them for a long period for about 10 years in 2018. And the objective was to determine the prevalence of obstructive sleep apnea, COPD, as well as asthma, and overlap of any of these two conditions, as well as with a primary outcome of all-cause mortality in patients in each category of these disorders, and the effectiveness of PAP initiation and compliance in this cohort. So this is kind of one of their initial findings, which show the prevalence of each of the disorders at enrollment. And as you can see, of the inpatient cohort of close to 5,000 patients, 29% of the patients had COPD, about 7% had asthma, and about 15% of patients had sleep apnea. Only about 19, 7, and 1% of these patients had each individual disorders alone, and the significant amount of there are a significant number of patients who had overlap syndrome, with 2% of these patients, or 87, having all the COPD, OSA, as well as asthma, so triple overlap syndrome. And what this study, as I mentioned, its main purpose was to look at the all-cause mortality of these patients followed over a 10-year period. And what they found was that patients with overlap syndrome had higher mortality, overall mortality percent rate than those with single disorders alone. Patients who were treated with PAP therapy had significantly lower mortality than those who were not treated with PAP. Of those who are on PAP therapy, patients who are more adherent had significantly lower mortality than patients who were non-adherent to PAP. And the adherence was defined as wearing the machine for over 4 hours or 70% of time, or patients, which was also determined by kind of looking at chart checking for follow-up, as well as equipment refills and such. And to further see this more visually, this is Kaplan-Meier curve looking at the rates of looking at the mortality survival in each of these conditions. As you can see here, this is triple overlap syndrome, which has the lowest survival rate compared to some of the other overlap syndromes. And as shown here again, those patients with sleep apnea who were on PAP had significantly increased survival probability compared to those who were not on PAP, as well those who were adherent with PAP therapy had significantly improved survival than those who were not adherent. So this, the strength of this study was that this was a large longitudinal observational cohort study. They followed patients for 10 years, which is quite impressive, and was able to follow about 5,000 patients through the period of through the period. And this was one of the first large studies to assess asthma and COPD, as well as OSA overlap syndrome. There were some limitations to this study because this was a VA study. A lot of over 90% of the patients were male, and they tend to be older at average age around 60, older veteran population group. They also, this was a single center study and of course observational study, and one of the enrollment criteria was that they had to have a hospitalization at enrollment. So therefore it may have kind of picked for a single group of patients, and therefore had pretty significant mortality rate. The long-term PAP adherence is quite low, about 22 to 14%. And of course, because this was more of a chart review paper, there was some limited data collection. So conclusions and implications of this study is that asthma and COPD and OSA are all very prevalent, especially in the veteran population. The triple overlap patients of COPD, asthma, and OSA have higher long-term all-cause mortality than those in other groups, and that the treatment of PAP therapy, as well as increased adherence to PAP therapy, improves mortality significantly. So from this study, I would encourage diagnosis of these overlap syndromes, as well as initiation of PAP therapy, and also help to or encourage implementation of programs to help with compliance in these patients. Great. Now I'll take any questions.
I don't see any questions. I will just make the comment that it's really kind of shocking, like how high the mortality was just overall over 10 years. I saw that the mean age of the of the cohort at the beginning was only like 61, years of age. So just a, reminder of how not just morbid, but I guess, how much that affects mortality. And very nice to be able to see some of that data that the treatment seems to be associated with better outcomes. Though I guess we could speculate about whether that's, just due to treatment of these specific conditions or whether these patients are more adherent overall to other therapies as well.
Yeah, and I think that was one of the, limitations in that they tend to pick more sicker veteran population. But definitely, I encourage, treatment and and identification of these patients early.
Okay. All right. I want to thank all of our panelists this morning, and now I will stop sharing my screen, and we'll go on to the next presentation. Thank you guys so much.